Welcome to everyone to Talk 4 of Men's Health Week. I said to my wife yesterday, I've never been this excited to interview someone since I was about 10 and first met Dr. Harry Cooper when I was convinced I was going to be a vet, but I'm a physio now. And so I've just got a quick bio for Professor Robert Newton, who's joining me today. So he's the Professor of Exercise Medicine in the Exercise Medicine Research Institute and Associate Dean of the Medical and Exercise Sciences at Edith Cowan University in Perth. Prior to his appointment there, he was the Director of Biomechanics at Ball State University in Indiana and also at the Pennsylvania State University. His current major research directions include reducing decline in strength, body composition and functional ability in cancer patients, cancer-related fatigue and the influence of exercise, especially the mechanisms of exercise as a medicine in suppressing cancer progression. He's an accredited exercise physiologist, certified strength and conditioning specialist with distinction, fellow of the Exercise and Sports Science Australia, and fellow of the National Strength and Conditioning Association. And the next part's huge. He's published over 800 scientific papers and his work's been cited over 19,000 times. And as of this year, his work and his team have attracted over $38 million in competitive research funding, which is just amazing. He's also extensive track record of research consultancy in developing maximum strength and power, which led to him being a consultant to numerous professional teams, including the Chicago Bulls, New Jersey Nets, Indianapolis Colts, England Rugby, Manchester United, and the English and Australian Institute of Sport. And so with such a huge bio, Rob, how do you keep fit and healthy?
Well, I'm almost 60, so I'm getting up there in age. So more and more time it becomes crucial that I try and stay as fit as I possibly can. So that's important for me. And you have to talk the talk and walk the walk. I don't think you can ever ask an athlete or a patient to do something that you're not doing yourself. So look, I'm right these days. I'm right into high intensity interval training now. So my wife and I 3 mornings a week at 5:20 in the morning, which is a little bit hard in winter now. We're off and we do a 47-minute high intensity workout. Got a bit of boxing in there, a bit of resistance training. So that's quite good, pumping iron. Swim once a week. This afternoon I'll run. I'm not much of a runner these days, but I try and get one run in a week. So I'll be doing 7Ks tonight. That's about my limit these days with arthritis and dodgy knees.
But we know exercise is great for those things as well. So you're not going to stop.
Absolutely. Keeps you from falling apart.
And so your early research days mostly worked around athletic populations and power, and you still are in that space. But what kind of led you down to the role of exercise as a medicine in chronic diseases?
Well, that's a really interesting question. It would go back to 1994, actually, when I went and did a research sabbatical with William Kramer at Pennsylvania State University. And I was doing work on elite athletes. And of course, Penn State's a Division I school, and incredible athletes there, football in particular, basketball, but also volleyball. And I was doing research on volleyball players because I was very interested in the biomechanics of how they can jump so efficiently. And I went out one night to train one of the players. It was a Friday night, and it was snowing. We had something like 300 inches of snow that year, and it was just a really snowy winter. And I got in a little car that we bought, this really old Chevrolet that we bought. And anyhow, I drove out to the arena to train this athlete. I got there and he wasn't there, and I waited for about 2 hours and didn't turn up. And I gave up and went home. And by the time I got home, the bottle of wine that we'd opened Friday night to have with dinner, my wife had finished by herself. And she said, "Oh, how'd it go?" And I said, "Oh, the athlete didn't turn up." And she said, "I don't know why you do this athlete work. It's meaningless. It doesn't contribute to anything." And look, at the time I got a little bit upset. And I went, "Oh, no, I think it's important to understand human function." But that was a bit of an epiphany for me. I still love the elite, the athlete work that we do. And we still have a fairly, personally, I have a large program of research around that as well, and several PhD students. It is still very, very important for a number of reasons, which I'll explain. But it was at that point that I thought, no, I'm going to have a look at how if I can apply all of the exercise science that I've learned and start applying it to different populations. And the first population, which is a study I started at Penn State, was in older men. And it was very much about increasing strength and power. So I took what I'd learned. My PhD previously was in maximising explosiveness or ballistic power. And a major problem as we age, of course, is reduction in muscle quality, quantity, and functional capacity, particularly around strength and power production. And I thought, can I apply all I've learned in training, elite basketball players, football, etc.? Can I apply it in older men as a starting point? And it was that point we ran a trial where we had old men. The average age was 72, and we had them doing vertical jump with weight. So they had barbells on their shoulders and weighted dumbbells and things, and we had them doing explosive training, which was unheard of back in 1994. But we produced considerable improvements in physical function, and so that was quite exciting. And that was my first foray into that. And but I didn't really get into the chronic disease area until 2003, when I moved to from the US. I was at Indiana at the time at Ball State University, and I got an opportunity of a full professorship at Edith Cowan University. And not many of them floating around, professorial chairs in Australia in exercise and sports science. So I grabbed it with both hands. And one of the areas that I wanted to pursue there was the application of exercise as a medicine for cancer management. And that was motivated by a few years earlier than that, my father passed away from prostate cancer. And, whilst he received very good medical care, there was no follow-up. There was no rehabilitation from the surgery that he'd had, the radiation therapy that he'd had. And I thought, gee, you had this overwhelming fatigue, and all the doctors and nurses said, you just have to rest. You've had cancer, it'll take a while to get it, just rest. And I knew, my core as an exercise scientist, it was wrong. And so what I proposed to ECU was to launch a program of research around applying exercise in cancer populations.
Yeah, right. That's fascinating. Well,
I'll try, Tom. I'll try to keep all my rest of my answers a little bit shorter than that one.
No, that's just it's amazing. And so that was my next question. Was initially exercise was thought to be of no benefit or potentially dangerous for cancer populations.
Oh, absolutely. And even in 2003, when I launched these ideas, certainly in the lay public, the thinking was that, I'm unwell, I'm sick, I need to rest and recover, I need to lie down. And, with my father, after his radiation therapy, it induces a lot of fatigue. So he's very, very tired. But it's not the fatigue that, you or I feel, when we've been working hard all day, mentally or physically. It's a different type of fatigue. And very much is driven by declines in physical capacity, aerobic capacity, muscle quality and quantity, decreases in strength. And that's what drives the fatigue, as well as a whole lot of immune and inflammatory processes as well. And so rest is not the answer. You have to actually rehabilitate and build the capacity of the system. But that was not well understood back in 2003. And it was still, if I think back when I first went out and started talking to the oncologists in particular, explaining what I wanted to do, half of them would say, look, exercise is fine. It's not going to hurt the patient, but, it's not really going to help them. I mean, they've got cancer. How's exercise going to help? But there was about 50%, I would say, of oncologists who say, no, that they can't exercise. It'll make the cancer worse. It'll exacerbate it. The thinking was that if you exercise, it would increase your metabolism and that would feed the cancer, or it would increase blood flow and that would give more nutrients and oxygen to the cancer cells, and they'd break off and metastasize more quickly. We move almost 20 years later, and we know that all of that is false. There's not a single study which has demonstrated that targeted exercise actually exacerbates cancer. And there's now literally thousands of trials, high quality, randomized controlled trials, which show considerable benefit for cancer patients. So a huge change in thinking since the early 2000s.
And what are our current recommendations for cancer patients with regards to exercise?
So last year, my colleagues and I published the Australian position statement for Exercise and Sports Science Australia on exercise medicine in cancer management. And very much the message around that was that it has to be tailored to the individual patient. We've been working since 2009, 2010 on a general recommendation that patients should try to complete 75 to 150 minutes of vigorous to moderate aerobic exercise and 2 or more resistance training sessions per week. And this is really based on the ACSM recommendation for healthy older adults. And this understandably caused some concern among clinicians and patients because they go, well, you know, I have cancer, I'm undergoing chemotherapy, for example. I've got a lot of morbidities associated with that. I mean, is this the right recommendation? That seems like a lot. And, you know, over the last 16 years, as we've been doing these various research trials with various cancer populations and at various stages, including advanced cancer, what we've seen is that generic recommendation simply does not work. And it may, in fact, cause an overreaching syndrome within the patient, whereby it might, it hasn't been proven, but certainly some very nice work by Dr. Lee Jones out of Memorial Sloan Kettering Cancer Center in New York City. He's published some nice papers in advanced breast cancer, where he gave, you know, not an excessive amount of aerobic exercise, but certainly he observed maladaptation amongst these patients. They were not responding well. It possibly exacerbated their fatigue slightly. So we now know that recommendation, whilst it might be appropriate for a patient who's been through their treatment, they have no, you know, marked ongoing toxicities or side effects of treatment, and you know, they're doing relatively well, the generic recommendation might be okay. But certainly for patients preparing for treatment or in treatment, or those that are you know, have only recently come out of surgery, chemotherapy, radiation therapy, no, it needs to be tailored considerably. And the tailoring really involves prioritising those health issues which are causing the greatest problems for the patient, whether it be impact on quality of life or function, body composition, or their actual mortality. You know, if there's a particular factor such as very low cardiorespiratory capacity or considerable cachexia, loss of body weight and particular muscle mass, you have to get a handle on that. You have to focus on that. Everything else doesn't matter, because, you know, if they're going to, you know, if they're at risk of dying because of these particular morbidities, then that has to be the priority. And so very much we recommend a tailored approach based on the health and physical fitness assessment of the patient, but also matching in with their goals and desires. You have, you know, obviously it's the patient who's in charge, and you have to very much work towards what their needs are.
Yeah, great, Rob. That's like it's so good to hear that kind of message. That, you know, particularly for some clinicians, that we need to kind of step out of our own shoes and go, you know, what's right for this patient, and it might not be necessarily our biases. If we're biased towards aerobic or strength training, it might be the exact opposite, and we kind of need to think about it and go down that way.
And look, sometimes you have to, you know, work with the patient and get them to understand priorities. I mean, some patients will go, I just like to walk. Well, you know, if the patient has, you know, bone density issues, walking is not going to do anything for them. You know, I'm sorry, but you're going to have to lift weights, and you may have to do some form of impact loading to try and stem the decline in your bone health. So it is, you know, it's a process of helping them to understand what the priorities are in terms of their quality and quantity of life, but also matching that with what their aims and goals are.
Yeah, it's just there.
I mean, me, I don't like running, but I'm still running this afternoon. It's just something I've got to do.
Yeah, I don't like swimming, but I can counter out that by going for a run. So I'm going to go into a few more specifics around exercise and cancer, and the next one's a bit of a big one, but just briefly-ish. Exercise-induced immunotherapy. What's all that about?
Okay, so the big thing in cancer care at the moment is around therapeutics, is all about switching on the body's own immune system. So when we talk about immunotherapy, it is pharmaceutical manipulations of the body's internal immune system. How do we actually turn it on so it's better able to locate and to identify cancer cells and then be able to destroy them? Exercise does that very, very effectively in its own right, because when we do exercise, we get quite a marked change in our internal physiology and chemistry. We get a whole lot of signaling proteins that are released, cytokines, but also hormones as well, which then cause the release of different immune cells, in particular T cells, natural killer cells. And we know from a very large range of studies that then, if you like, upregulates your immune system and makes it smarter, better able to actually identify what is wrong, what cells shouldn't be there. In other words, the cancer cells. So this has been demonstrated quite well, predominantly in preclinical studies, so in animal studies. It's difficult to show this in human studies. Certainly, in human studies, it's been well demonstrated the immune function benefits of exercise, but not the direct connection between that and actual cancer suppression. That's mainly been shown in animal studies quite effectively, but also in vitro studies where human serum, so blood, extract the serum, pouring it over different cell lines, we see a massive suppression of cancer cell growth.
That study is one of my favourite studies, the one where they took the high intensity bout of exercise and then got the 31% decrease in cell activity. It's incredible.
It is. That was the landmark study which said, well, hang on, something is released when we exercise, which has a strong anti-cancer effect, and somehow signals to the cancer cells to shut down and to not proliferate. That was shown in healthy men in that particular study. We now have one of our PhD students doing a similar study, but he is actually involving men with prostate cancer. And so looking at see whether the same effect, again, men with prostate cancer, drawing blood pre and post an acute exercise bout, and then putting it over cancer cell lines in vitro to see if we get the same suppression effect.
And with exercise, so we know a regular bout of exercise will get, it helps with the regulation of our blood glucose levels. How important is that with regard to cancerous tumours?
So for many of the key cancers, in particular, your breast cancer, colorectal cancer, prostate cancer, it's a major problem in patients who have type 2 diabetes, patients who are glucose intolerant. And the reason why is that their blood glucose level is higher than what is healthy. And tumor cells are anaerobic. And so they love glucose, and they don't really use fat for energy. And so having a high glucose level is promotional for the tumor cell growth. But also insulin is promotive as well. Insulin obviously has a very, very important function in the body, but if it's elevated chronically, for many types of cancer cell, it actually encourages growth.
And then following on from that to a degree, we also know when we exercise, we get angiogenesis, so an improvement in the vascular system, so more blood vessels to allow better blood flow throughout the body. How does that affect cancer to a degree, and how is that helpful?
Well, that's an interesting one, because the thinking was that we should actually starve the tumour of blood. And so there was many pharmaceutical interventions developed which actually interfered with the development of the blood supply to the tumour, and thinking that if we starved it of oxygen and nutrients, it would grow more slowly. Unfortunately, that's not the case. Cancer cells as I said, they prefer a hypoxic environment. They're anaerobic in terms of their energy source, and they actually thrive in a hypoxic environment, whereas healthy cells don't do as well. So it causes the cancer to tend to overtake. The other thing is that if it is a hypoxic environment where you've got poor blood flow through the tumour, it also causes disruption to the cell, to the capillary walls. So the actual circulation is poor, it's leaky, and this encourages tumour cells to actually leak out of the tissue and into the blood supply. So it's well shown that the risk of metastasis is much higher in tumours that have poor blood circulation and are hypoxic. So there's been some very nice work done showing, once again, in animal models, that if you exercise the animal, that the microcirculation within the tumour is much more organised and more normal. And that we see suppresses rate of growth, potentially because with better circulation, you're delivering more chemotherapy agent, you're delivering more of the body's innate immune system, so more natural killer cells, etc. And so also acutely when we exercise, it's interesting, as you know, when we exercise, a lot of the tissues of the body reduce their blood flow. We have vasoconstriction to provide as much blood as possible to the working muscles. In tumour tissue, that doesn't occur. The vasoconstriction is suppressed, and so they stay open. When we exercise, blood pressure goes up, so blood perfusion and flow through the tumour is much, much higher. So that's important in particular for the delivery of chemotherapy, and also the oxygen enhancement effect of radiation therapy. So radiation therapy is not as effective in tumours that have poor blood flow. So again, we have a trial which we're running where we're exercising the patient immediately before they commence their radiation therapy to increase blood flow and oxygenation in the actual tumour. So when it's irradiated, you'll get a higher rate of cell death.
Yeah, right. And I wasn't aware of that one. That's huge. Like I knew around the chemo side of things, but radiation as well. That's pretty massive.
Yeah, it's a very exciting aspect to it because it's very well established, and I don't think anyone would argue that exercise improves quality of life. And for the patient, quality of life is number one, obviously, and even for the clinician, that's where their focus is. But what we're seeing more and more now is exercise used as an actual enhancement for the primary treatments. So in particular, chemotherapy and radiation is important that the patient remains active during that phase, because it may actually make the treatment, the primary treatment, actually more effective, whilst also reducing the side effects and toxicities of the treatment.
Yeah. And while we're talking about different treatments for prostate cancer, for example, for men undergoing a prostatectomy, so removal of the prostate, what role does aerobic and resistance training play in helping to reduce incontinence and erectile dysfunction post-surgery?
Okay. Gee, how long have you got? Look, there's so many reasons why exercise as a neoadjuvant treatment is so important around surgery. So neoadjuvant means it's a treatment which is done before the primary treatment, in this case surgery, to make it more successful. And there's all of the pre-surgical issues as well. I mean, obviously a patient going for any form of surgery, it doesn't matter what it is, it doesn't have to be cancer, but any form of surgery, a patient going in with better aerobic and musculoskeletal fitness is going to do better. They'll do better under anaesthetic, they'll recover faster, they'll have a less infection risk and less time in hospital. So that's pretty well established now. In terms of the using it leading up to surgery, there's many applications. We've just got a paper about to go out where we looked at very rapid weight loss prior to surgery. Unfortunately, in Australia, 2/3 of men are overweight or obese. This is a problem in terms of prostatectomy. It's harder for the surgeon to do the surgery. Obviously, the patient is chronically inflamed. They're at higher risk of surgical complications, post-surgical infection, etc. And so we've just completed a study, and as I say, we've written the paper up where we looked at a very rapid weight loss in the 8 to 10 weeks leading up to the prostatectomy. And very good success with that in terms of fat loss with that. So there's that aspect to it as well. And if the surgery is less complex and is easier, you'll have better nerve sparing. There's less likelihood that you're going to have erectile dysfunction and incontinence. But also, I think, obviously strengthening the muscles prior to this insult of surgery, pelvic floor exercises, but also we're looking at strengthening all of the muscles around the pelvic region, in particular your very large muscles like your gluteals. Very important that they're of really high strength and high mass before the surgery, because they're going to decline as a result of surgery. And so we work very hard on that. And then post-surgery again, I think we spend a lot of time on pelvic floor exercise, which is important. It's shown very good efficacy. But we forget all the larger muscles in that area as well, which are also very, very important, not the least because they're going to be producing more of these cytokines, which help with repair. Obviously doing whole body, large muscle group exercise, you get an increase in testosterone if the man's not on testosterone suppression, but increasing growth hormone and all these other positive hormones, and the cytokines as well, which will all help to facilitate that repair in the pelvic region.
I completely agree with all that. So I think it's the more the man moves, the more the pelvic floor is naturally engaged as well. But also, the stronger all the other muscles are, the more they can help offload the pelvic floor when they go to move as well. And
absolutely, yeah.
And then coming back to the fat loss, I was fortunate enough to watch a surgery, a prostatectomy a few years ago, and it's amazing, like, to see inside an abdomen, and you can see these fat cells, and that just create their own blood supply, and the blood loss during a surgery of someone who is overweight compared to someone who isn't. It's insane. Like, it's incredible how much harder that operation is for a urologist to do.
It is, and the surgeons report to us that in these overweight patients that everything's inflamed, everything's adhering, the tissues, etc., and it just makes the surgery more difficult. So the outcomes are not going to be as favourable. So yeah, a major target now, and with prostatectomy in general, there's no great rush to get in there. We're seeing an 8 to 10 week period there. It's ideal to get the patient's fat mass down, muscle mass up, and try and get their fitness up as quickly as we can.
Yeah. And what about more advanced cancers? So patients that may have a bit of a bony metastases, etc. Like, should they still be exercising, and is it safe for them to exercise as well?
Again, Tom, it comes back to this highly tailored prescription, and that's why one size doesn't fit all. So the original recommendations that, look, we put it in our 2009 position statement for ESSA. We put it in this idea of 150 minutes of aerobic exercise and 2 or more resistance training sessions per week. But certainly even more so in patients with advanced cancer, it has to be highly tailored, in particular if they've got bone metastases. So we were the first group in the world to run an exercise resistance training study in patients with bony metastases. And what we did with that study was we exercised all the bits that weren't affected. And we're just borrowing on this enormous volume of knowledge and research around high performance sport and athlete performance. What we've learned about astronaut survival, what we've learned about warfighters, soldiers, and how do you increase their performance and keep them alive. So all of that body of work, which is enormous, now we're actually applying it in the clinical medical environment. And well, we don't have any sport on at the moment, it's all cancelled, but some of it's coming back, but with no crowds. But if one of the West Coast Eagles gets injured on Saturday, the coach doesn't say, "Well, that's a shame. Why don't you have 6 weeks off?" It just doesn't happen. They're in the next day, and we just exercise all the parts of the body that aren't injured. And so we applied this with the patient. So if they have a bony metastases in their right humerus, for example, then we just exercise the other arm. And So that was our philosophy. However, there's been some very interesting research, animal work again, showing that if there's controlled loading on the bone, it actually suppresses the progression of the bony metastases. And it's probably some local signaling there. As you know, bones are very active tissue. When you put force through it, you get all sorts of chemical and electrical messaging going between the various bone cells. And it appears that that is also signaling to the tumour cells and actually shutting them down. So we've completed 2 studies now, one in advanced prostate cancer and one in advanced breast cancer, where we've actually patients with bone metastases in their spine, and we've been using isometric contractions to place a controlled amount of loading on the bony site. We've had no exacerbations of bone pain with that. It appears to be safe in that very well-controlled, monitored environment. So I think in the future we'll see quite tailored exercise prescriptions, passing some amount of load through the actual site of the bony metastases, but it might be a while before it moves from the research trial into actual clinical practice and recommendation.
Yeah. Before you touched on the initial trials and oncologists that were for it and ones that were flat out against it. In terms of exercise and medicine for people, prostate cancer, for example, who do you think should be advocating a bit harder? Should oncologists, GPs, people like myself, urologists, be urging their patients more to undertake the exercise, or do you think it's up to some of the patients to advocate for a suitable referral to their treating team?
Tom, as you know, I mean, all patients are different in terms of their background, in terms of how demanding they are. To a certain extent, it's probably a generational thing. A lot of our older patients, they just, the physician's always right. The physician owns my medical care and information. That's shifting, obviously, markedly now. I mean, we're trying to get the health consumer, the patient, front and centre, the centre of the universe. So it is probably changing. We know from experience that one of the greatest drivers for a patient changing their lifestyle is their primary care physician saying, hey, do you want to survive this thing? You're going to have to change what you're doing. We see in terms of the patients that come to our exercise trials and volunteer, it's because their oncologist has said, look, this exercise trial is running. I think you'll get some really good advantage out of it. I think, I recommend it. And that's probably the strongest. The other one would be family, I think, as well. The partner has read or seen a webinar like this and go, wow, you need to do some exercise. And, that's a strong motivator as well. And say, hey, look, I need you to hang around a bit longer to be with me. So I'd say their oncologist or their general practitioner are probably most influential, and next would be their very close partner or close family member. Yeah.
We're coming back to exercise and how do people monitor it. So we're talking about moderate to vigorous intensity. Are you more an RPE, rating of perceived exertion type team, or with the resistance stuff, for example, are you going towards repetitions in reserve or something completely new?
No, we use both of those, Tom, and extensively. We use RPE every single session. And it's the same with our resistance training. We always say, look, you need to leave 2 in the tank, so to speak. There's no evidence at all that going further than that has any additional benefit, and there's no reason to do that. We use both of those methodologies to monitor intensity.
Yeah.
We also use a lot of wellness checking. So when the patient comes in, or we send out an electronic form for them to do on their phone, and it's just a couple of questions about, how tired do you feel today? How well did you sleep? Do you have any pain? And has anything changed in your medical condition since last time we saw you? So we use those wellness checks. And again, that's straight out of elite athlete management. Yeah.
And then you'll modify a session if they've obviously had a terrible night's sleep and death in the family or something like that, for example.
Again, straight out of elite athlete management. We use auto-regulation. So if the patient comes in and they're feeling pretty sharp, then we bump up the intensity. If they're feeling pretty flat, then we adjust it accordingly. It's very rare though when we say, look, you know, do you want to just go home and rest? In general, if they've come in, then we say, oh, well, why don't you do one set of leg press and then, you know, go and have a coffee. It's pretty rare that they'll finish up after that. They do the first set and they went, oh, okay, I still feel like crap, but I might as well finish the exercise and do another couple of sets. And quite often they'll finish the whole workout. Because as you know, as soon as you start to exercise, endorphins kick in, pain suppressed, nausea is suppressed, and you know, it's just making that start in the session. But we never push them. If they come in and they feel really lousy, then, you know, we might just put them on a bike, go for a bit of a pedal just so they're doing something. You know, even just put them through a stretching session or something like that.
I think it's great to hear, like, for people listening to this later on, but, you know, elite sport can sometimes get a bad rap about all this money that's spent and all these dollars and everything, and particularly at the moment with everything's going on in the current climate. But to hear like how it then transfers through a whole clinical population, I think it's an important message that you know, sport matters as well, because it helps to guide other management, definitely.
Oh, absolutely. And without the money in sport, you wouldn't be able to do the research. I mean, only in the last, you know, 10 years, I would say, you know, the real money has started to flow through to exercise medicine research. Previous to that, the grants were relatively small, but, you know, now you're seeing NH and MRC grants of $500,000, $1 million being awarded for exercise medicine trials. We currently have a trial ongoing, international trial funded by Movember, for 10 million Australian dollars. And, you know, that's to look at exercise and medicine in men with late stage prostate cancer, with the outcome being, can we actually increase their survival? So prior to that, there just wasn't the investment. But of course, rightly or wrongly, the military in particular, various countries around the world have invested billions and billions of dollars in trying to understand how the human responds to physical exercise, and how to make the warfighter more resilient. Same with the athlete. How do you keep an athlete out on the field week after week? You know, how do you patch them up? How do you recover them? So the volume of knowledge around that is quite enormous. And, you know, we're only just starting to actually translate that across to patients, including cancer patients.
And just briefly on a couple of trials you've got going at the moment, the interval trial, is that the Movember one? That's
the Movember trial. So a whole range of reasons for that. These men have advanced metastatic cancer. So the median survival is about 33 months. And what we need now in terms of changing government, and not changing the government, but changing their actual, the laws around Medicare in particular, is to get more support for exercise medicine. Because at the moment, as you know, if the patient has cancer, they can go to their GP and get a general practice management plan, and that gives them up to 5 sessions with an exercise physiologist or a physiotherapist or a dietitian, etc. Which is not a lot. I mean, it's, you know, it's $68 or $58. I should know that. By 5, you're talking about an investment per annum of around, you know, $250, $300. It's not a great commitment to exercise medicine by the federal government. The only way we're going to change that is by showing an actual survival advantage, because if we can show, in this particular study, we're trying to demonstrate that targeted exercise will produce the same survival advantage as the top drugs at the moment, which is these super anti-androgens. If we can demonstrate that, then patients will demand exercise medicine and clinicians will require it. And it's only then, I think, that we'll actually see that governments around the world will put more of taxpayer money into support exercise as a medicine.
And you've also got an active surveillance trial as well?
Yeah, so that's the absolute opposite end of the spectrum. So we've got one in prostate cancer patients who are now palliative, end stage of life. But at the other end, what we're looking at is men who've been diagnosed with prostate cancer, but it's very low grade. And the issue is that in the past, bang, they would have been recommended for surgery, or they would have been put on androgen deprivation therapy. And like my dad, they would have had a whole lot of side effects of that. And like my dad, 2 years later, they would have died of something else, most likely cardiovascular disease. And so we've learned from that, and you know, in a man which hasn't got an aggressive prostate cancer, it's probably best to leave them alone and just wait and see. But that's difficult for the patient. You know, the patient goes, "Oh, what are you going to do? Nothing." It's no. We're going to, you know, we're going to regularly see you, and we're going to monitor it. It's called active surveillance, and we'll see how it goes. It doesn't pass the pub test. You know, the guy goes down to the pub and they say, "Oh, you know, how you going?" He said, "Oh, not too good. I got prostate cancer." And, "Oh, geez, mate, what are you doing about it?" "Nothing." His mates go, "Okay, interesting approach." So what we're doing though is trying to improve their decision satisfaction in going with active surveillance. For a whole range of reasons. There's a very nice study done in the US in men in similar situation. And what they did, fairly heavy intervention combining exercise, meditation, mindfulness, and a vegan diet. And what they showed was they pretty much stopped the progression of the disease in its tracks. They reversed a lot of the markers of the prostate cancer progression. So it could be a lot of the prostate cancer low grade that by using exercise medicines and dietary changes, getting control of your stress, body fat, etc., you may be able to slow the disease to the point that it's not going to be a problem for you, and you can just leave it alone. It also passes the pub test, because when the guy goes down and says, "Oh, I got prostate cancer," his mate says, "What are you doing about it?" He says, "Oh, I'm taking exercise medicine." "Oh, okay, that sounds good." Bang, you have a beer and you move on. So that's the basis of that study.
Yeah, cool. It's great. Like it's hitting all the boxes. Yeah, I like the pub test. You know, hopefully his mate who's got cardiovascular disease goes, "This exercise medicine thing sounds good. Maybe I should talk to my GP about it."
Oh, that would be good.
Finally, Rob, we know clinically, you know, sometimes it is really hard to sell exercise. And so you meet someone who's been living under a rock, they've never heard of exercise being a medicine. How would you sell it to them?
Oh, look, the same way in which I sell it, I guess, to the patients and I guess more so to the clinicians. I mean, clinicians well understand the mechanisms of exogenous drugs. You know, they understand the action of cholesterol-lowering drugs, and they prescribe them, and they're effective. And the way I describe it is that exercise just switches on the body's internal drug factory. It's in your internal pharmacy. Because when we exercise, our internal biochemistry shifts markedly. It acts to help you overcome the decline due to cardiovascular disease. It stops bone loss. It stops muscle loss. You know, and these are basically chemical. So you are producing endogenous or within drugs. So exercise is a medicine. I was in a meeting the other day, a teleconference, and it was a fairly high level meeting talking about funding for grants in neurological conditions, and and one of the physicians there was just adamant. He said, "No, exercise is not a medicine. It's just it's a side thing." He said, "Look, it's very important. I think it's fantastic, but it's not a medicine." And we talk about so many other therapeutics which actually we call medicine. Because they produce actual chemical changes or physical changes, structural changes within the body. Exercise is no different to that. It produces, in some instances, much larger positive benefits in terms of the internal biochemistry than many of our top drugs.
That's great. That's great, Rob. We've got one question that came through on the line. So many trainers simply apply generic solutions. What efforts are being done to help educate non-medical fitness trainers? So I suppose your PTs rather than your exercise physiologists.
My passionate belief, and within Australia, but also it's front of mind in many other countries, Canada, the US, certainly in the UK, is that if we're going to get any handle on the chronic disease avalanche, which is falling on us, we have to utilise the enormous capacity of the fitness industry. And simply, we cannot rely on in-hospital or allied health care for the millions and millions of people that have rapidly advancing chronic disease. I mean, we have a rapidly aging population, rapidly increasing rate of chronic disease because of poor lifestyle, disease we don't have to have. Certainly, physical activity is a major factor in turning this around. The only way we're going to achieve that is to pull on as many resources as we possibly can. And one of those is to actually utilise the fitness industry in terms of not only the actual infrastructure, but also the huge capacity around expertise. I mean, obviously, fitness professionals are very trained around motivating people, but also in monitoring their exercise. And so we have to actually utilise that. We do, I agree, need training. You know, obviously, you know, ECU's got one of the largest exercise physiology courses in the country. And, you know, I teach all of the exercise oncology components, and, you know, it's 2 lectures and 1 lab in a 4-year degree. So even EPs coming out do not get enough oncology training as well. So at ECU, we've introduced a graduate certificate, graduate diploma and a master's specifically in exercise oncology for that reason. So we've got to upskill our exercise physiologists as well to work with cancer patients. So still many I talk to are really uncomfortable, and they fear they lack the understanding and skills to work with this patient population, particularly those with advanced disease. Same with physiotherapy. We have to increase and upskill them so that they are more comfortable working with these populations. And again, I agree with the person who's called in. We do have to upskill those that are interested, those fitness professionals, personal trainers, fitness instructors, so that they can actually work with these cancer patients in their facility.
Thanks, Rob.
Now, that's not for everyone. You know, if you have it's all about setting and the individual patient. You know, I don't think we can't get to the point where a patient with advanced metastatic cancer can be going down to their local gym, training by themselves, or having a personal trainer actually supervising them. And it's nothing about the profession or anything like that. It's just the wrong environment. It's the wrong setting. That sort of patient probably needs to be in a hospital or a cancer centre, in an exercise, an exercise clinic, which is, close to medical care and emergency support if required. Having said that, we've had, over the last 16 years, approximately 250,000 patient contacts. During that time, we've only had 4 serious adverse events and no fatalities. So a key message is, under proper supervision, in the right environment, with the proper safety in place, your risk of having a serious adverse event under exercise, regardless of whether you have an advanced chronic disease, is very, very low.
That's a great little message there, Rob. I'll let you go. My final thought before today was the thing that I suppose I love so much about the research you guys do over there, particularly around exercise. It all gives patients hope. Like, that you're diagnosed with cancer and you're kind of dictated to a lot of pathways for a while. And then, often people say, well, what can I do? Because they feel like they're just being spoken to and talked to. Whereas all of this evidence now, you give that person hope that if they go and exercise, and yes, there might be some barriers, but they're just about always work throughable. And you can get moving, and they feel so much more hopeful and thankful for exercising.
Yeah, absolutely. I think what is a common theme with a person with cancer is that loss of control. They're getting things put into them, they're getting things taken out of them. The issues around finances, around work, family, everything else. Many of our patients see the exercise as something they can actually do and actually have control over, and that's very important for their physical health, but also for their mental health. And COVID-19 introduced a whole series of challenges because our patients could no longer come into our clinics. And, they reported that they were alone, scared. They were reporting that their physical and mental health was declining because they couldn't exercise. They couldn't come in and exercise with their peers. And we certainly had to get our skates on and ramp up our telehealth very, very quickly. And within a couple of weeks, we were able to roll the exercise prescriptions out to the patients on their smart device or computer. And we draw obviously extensively on video chat as well to supervise them. also, and that was right across all of our trials, but also our clinic patients as well. You do notice that the exercise has enormous psychological benefits for the patient well beyond the physical as well. And that's a good point, is that the fact that it is something that they can manage and control, but also it's that mixing in with other people. And we've seen that they can mix in virtually as well. I mean, we have virtual exercise sessions set up where they're still exercising with their friends and mates that they did when they were in clinic, but they're doing it in a video chat format.
That's great to hear. And it's always, COVID threw around plenty of challenges, but there's always a workaround.
Yeah.
All right, Rob. Thank you so much.
Oh, pleasure. Thanks for your time.
Can't thank you enough for joining us today. Happy Men's Health Week. And we'll catch up with you if you're ever back over in Brisbane once the borders open.
Absolutely. Yeah, that's great. Thanks so much, Tom. Appreciate the opportunity.
Thanks, Rob. See ya.
Bye.